Okay. Okay, go ahead.
Okay, so starting again, in this particular dynamic here, when you went to your primary care physician, nurse practitioner, or PA, and they said, you know, you're sick, you've got pneumonia, or you've got the flu, and we're going to get you through the system here, we get you back on the far end of this. I didn't really talk about the things that you could do to move yourself faster through this system. And of course, we could also talk about prevention, but let's just go back to your healthcare continuum, your personal continuum. Here you were, feeling good about yourself, going for your flu shot, sat in an office, got your flu shot, you were in with a bunch of toxic people and ended up getting ill. You went to your physician, you ended up in the hospital, and they got you kind of unsick. It's up to you to get yourself well. But let's talk about how fast it was to get you unsick. In the healthcare system, current overprescribing, overutilization, it's currently estimated that there's $750 billion in unnecessary healthcare just in 2009, the last year that this data was reported. And there's a new report being collected right now, but I think if we just apply the 2009 numbers, it's still an unacceptable number. This is not the total cost of healthcare, which is in the trillions. This is just the unnecessary healthcare spending, the waste, abuse, misuse. And there's a lot of efforts within the government to reduce this. But when you treat people on autopilot, you know, okay, you meet the criteria for admission, so we admit you. You meet the criteria for the ICU, so we stick you in the ICU. You meet the criteria to depart from the ICU, so you depart from the ICU. You meet the criteria to survive, to get out of the hospital, let's get you out of the hospital into some other portion of the healthcare system. Well, that's not an acceptable way to do it. That's not the way we want to do it. But when you take the data that came with this report, and you take the 33.6 million admissions in the hospital in 1997, and you use the data that came from that, 44,000 Americans die each year as a result of medical errors. Now, in the New York study, which actually was validated, which I made reference to in the Institute of Medicine study, the number is closer to $98,000 a year, and that's anywhere within the healthcare continuum. That's misdiagnosis, mistreatment. But just to put that into some sort of a framework, motor vehicle accidents, and look at how much we do in motor vehicle accidents. 44,000 people a year die of that. Breast cancer, 43,000, and AIDS, 16,000. If I add these things up, I think that comes up to approximately 98,000. I think it's just over 98,000. But that's medical errors within the healthcare continuum each year. And this number is being slowed down, but it's not gone down yet. So this is just not acceptable within our healthcare system. And I'm going to pick out one particular part of this first, which is medication errors. 6,000 people die per year of workplace injuries. 7,000 people die per year of just medication errors. That's medication errors. That's not medication effect. It's just medication errors. And that's the number I actually thought would be a little bit higher, but 7,000 a year due to medication errors. It's not where we want to be with that. And I'm going to throw a little tease out here. You have a role in this. You have a role in reducing this. It's not just the physicians and the pharmacists and the nurses and the dietitians' job. This is your job too, to reduce medication errors. We'll talk about that as we get a little bit further on here. And how do we get to all of these deaths and all of these issues? One of the things that we do, how do we evaluate a good physician? Well, I went to the physician with a problem. The physician gave me an antibiotic and sent me home. True, I almost died as a result of the antibiotic, and it really wasn't necessary anyway, but I view them as a good physician because they gave me an antibiotic. They stuck me in the hospital when I felt bad, and they didn't discharge me because my family didn't feel like I was ready to go home. I was well enough to go home. Oh, really? Well, they left you in the hospital, and then you got infected, and then you died as a result of these healthcare injuries. Maybe that wasn't such a good doctor after all. In a 1999 study, and I realize this is a little bit dated, but I'll provide some background information on this. In a study of 36 hospitals and skilled nursing facilities, it was found that 10% of the medication administration was in error, 10% error rate. And that doesn't even include medications offered at the wrong time. And I'll tell you that in nursing homes, the on time means within 30 minutes of certain medications and an hour of certain other medications. In the hospital, those numbers are approximately the same, 30 minutes to an hour, one side or the other when it's prescribed, but some medications are a little more critical than that. A national observation study of the accuracy of prescribing practices in community pharmacies found that the error was 1.7%. Well, if you multiply that out, that means that 1.7% of 3 billion prescriptions per year is 50 million errors. What was the outcome? Well, it contributed to the harm rate. It may have contributed to the death rate. And now we have information to show that where the pharmacies get their medications sometimes may not always be the best. In fraudulent medications and incorrectly manufactured medications. And if you remember recently, the compounding pharmacy up in New England, where there was a problem there, which has caused deaths and serious injuries on a number of patients who were in ambulatory surgery centers. So the healthcare system understands these problems and is working to reduce these problems, but it requires that everybody be a player within the system, and that includes the patient. Now, I've thrown up here two of the federal regulations, or one is the federal regulations, and one is the standard of practice for medications. The 5 rights of medications. Has to be the right medication at the right time, at the right dose, right route, right patient. And then there's the federal definition of an unnecessary medication, which is without adequate indication, don't give me something for the flu because the medicine isn't going to help me with the flu. Don't give me a medication that won't work on my infected toe. It's got to be for the correct indication. Not in duplication, which is don't give me medications that have a lot of Tylenol in it, like Excedrin, and then tell me that I need to take Tylenol for a headache or for a fever. Just because it's for different purposes doesn't mean it's not duplication therapy. Don't give me one medication that thins my blood and then tell me that I can take another medication that has aspirin in it, which will thin my blood, or without adequate monitoring. You give me a medicine for blood thinning, and then you've got to check to make sure that that my blood isn't too thin, and also that I don't eat foods that will undo everything that my blood thinning medicine is supposed to do. The pharmacist plays a role in this. The physician plays a role in this, and sometimes other players have to play a role in this. And sometimes the patient has to learn themselves. If I'm sitting in the doctor's office, or if I go to the pharmacy and the pharmacy hands me a medication, and I've been taking this medication for 6 months, and I'm going to be taking it for most of the rest of my life, I better know what that medication looks like. And if they give me something that doesn't look like it, it's time to call for the pharmacist to come over to the counter and explain to me why this medication looks differently. That's my role. If I normally have a medication that I take once a day, and now I get a new prescription and I have to take that same medication twice a day, this is something that I need to wave the flag. I need to say, this isn't right. And same when I'm in a hospital. And I don't normally get a medication at 6 o'clock in the morning, When somebody wakes me up to give me a medication at 6 o'clock in the morning, I've got questions that I need to ask. That's my responsibility as the patient. Sure, it's their responsibility to get it right. It's my responsibility to get it right also. I have a role. So just in summarizing again, and if we look at the last 2 bullet points, 1/3 of the patients will take 5 or more different medications this year. It's 1/3 of adults, not just patients, just anybody in the community. And nursing home patients will take an average of 9 different medications every day. So what are some of the solutions? Well, one of the things that a physician or a nurse practitioner or a PA can do is to say to a patient, this is what I want you to know about your medications. This is how you need to help me with these medications. First, I want you to keep a list. And I want you to tell me all the other medications that you're taking. And then the physician can say, but there are other players in the system that are going to help you too, and you need to talk to them. You need to talk to the nurse, you need to talk to the pharmacist. Make sure that we all agree on your medications. The government also proposes to organize the healthcare units to deliver care safely. Part of that is staffing guidelines, part of that is supervision guidelines, like requiring that pharmacy technicians have to give the medication to a pharmacist before it goes to you, especially in the prescription mills that sit somewhere else, also known as mail order pharmacies. And we have to create healthcare organizations that foster safe care. And these are quality organizations that are out in front of healthcare, making sure that they have good systems, and after healthcare is delivered, making sure that the care that was delivered was correct. And these are organizations that go on in the background that a lot of patients don't see. And then establish an environment that enables healthcare organizations to deliver safe care. And that would be to require internal quality reviews, to require the involvement of the patient, to require the education of the patient and the healthcare providers and the advocates of the patient in all of the things going on with the patient, sharing that information with them in order to make sure that the care that's delivered is in fact safe, is in fact timely, is in fact to the right patient. The next thing I want to spend just a short period of time talking about is healthcare-acquired infections. Nearly 20,000 patients die each year as a direct result of infections, and infections contribute to the death of 80,000 patients per year. So some of these are unrecognized or just move so fast that they kill the patient before they even have an opportunity to come into contact with the healthcare system. And you can think of the meningitis cases that happen, or the fast-moving diseases that people get when they drink contaminated water when they don't know it. All of these infections, they result in a significant number of people dying per year. But looking at this first bullet, infections that people acquire while they're receiving treatment from another condition in a healthcare setting, that's the definition of a healthcare-associated infection. And these require all the players in the system to be part of fixing this. And that includes the patient. And there is resistance on the part of a lot of people in stopping the patient from being too heavily involved in this. Recent study of physicians and nurses within a healthcare system. How did you feel when the patient said to you, "Did you wash your hands? I didn't see you wash your hands." And their response was a very negative response to the patient involvement in that. And at the same time, there are so many studies that show that reminding healthcare professionals to wash their hands results in fewer infections and fewer deaths from infections and fewer resistance in infections. And there are countries in the world that are even attempting to outlaw neckties and lab coats. And as you can imagine, there's significant resistance in the United States to getting rid of neckties and lab coats. Wouldn't it be nice if every time somebody walked out of the bathroom and didn't wash their hands, this bell would go off saying, didn't wash hands? So, this doesn't go on. Same thing in the hospital room. There isn't a bell that goes off that says, didn't wash hands. Instead, healthcare facilities have created better environments for washing hands. They've added alcohol gel, which will work for some things, but not other things. And most hospitals even tell patients, you need to make sure I wash my hands, so just remind me. And then the reverse is true. Hospital workers will sometimes go to the sink and say, I'm going to wash my hands, and I'm going to show you, the patient, how to wash your hands when you leave the hospital, because this is what will keep you from infecting your family and other people. So it's a two-way street. Staff have to address this to patients. Patients have to address this to staff, and I know there's resistance. Patients don't want to tell the professionals how to do their job, and professionals don't want to be told how to do their job. But we go back to this, 80,000 deaths per year, 20,000 as a direct result of infections. I don't think this is where we need to be. This is certainly not where we need to stay. Now I'm going to put another very busy slide up here. These are, if you happen to move through a hospital, some of the people who you will come into contact with. And each of these people, when they come to see you, before they touch you, did they wash their hands? A way of knowing. I can pretty much so tell you this infection control preventionist will wash their hands coming in, they'll wash their hands going out. The pharmacist will see you, but what do they do inside the pharmacy? Do they clean clean out their trays before they put your medicines in it? As an inspector, I will tell you that there is an error rate. It's not a high error rate, but it is there, and there's nothing that you, the patient, can do about it. That is the healthcare's systems quality methods that need to determine that. But look at all of these people that are going to come to see you and that you're going to interact with. And each of these people feel that they have a responsibility for you and a responsibility to you. And each one will attempt to do it. But do you remember that slide that talked about the pre-flight checklist and the continuous communications that go on in some environments and don't in others? Many of these people have an opportunity to undo what other people are doing within the system. And that's why you as a patient being involved, knowing what you're doing and your responsibilities as the patient, it helps everybody else to communicate better. You take this same slide where you had the person at the center, you take this same slide and you put your home at the center, your personal home. Look at all of these clinical environments that exist out there. All of these organizations that have rules and regulations, they have the opportunity to help you. They have the opportunity to be a surrogate place for you to go to during care. All of these are possible places that discharge planner could have you interact with. And each of these places have an opportunity to help you avoid infection, avoid medication problems, each of these. And there are rules and regs for each of these. But I wanted you to see, in each of these places, I wanted you to see the name of each of these places. And there are others, and there are modifications of each. But these are clinical environments. And these are distinct from social environments. Here you see progressive living centers, assisted livings, veteran centers, counseling centers, adult daycare, group homes. All of these are places that might be a surrogate or a substitute for your home, and will provide some level of service for you. But maybe those services can be provided in your home. It's a balancing act. It's can you get benefit from one of these centers in this continuum of care that you're moving through? Or can they help you? Will they follow the rules? What are your roles and responsibilities in these centers? How do you keep yourself getting more well and prevent yourself from getting more sick? Now, it would be nice if, as you move through the system, you had sufficient authority that you could say, before we unload him, he'd like a price estimate in the emergency department. Well, the people within the healthcare system are not prepared for your full partnership yet, which is unfortunate. But, we're moving in that direction. You kind of do this in advance with your insurance company, if you have an insurance company, when they say, if you present for emergency care, you will pay $150. But if you go to urgent care, you will pay $75. Well, what is an urgent care center? I'll tell you that they are relatively unregulated. You go in some urgent care centers, it's basically a family practice physician's office that puts out an urgent care center sign. And you go to other urgent care centers, and what you have is an emergency department not attached to a hospital. How do you tell the difference? You can't. You have to go inside and actually ask. And they are not interested in you getting a price estimate, and frequently they are not interested in giving tours. This is one where your legislators have to take the lead. They have to say, you're going to declare yourself to be an urgent care center, you have to meet these minimums. If they don't say it, not going to happen. But if they hold themselves out to be an emergency department, hopefully they can provide emergency department services. But you agree with your insurance company where you will go for your cold and your flu. Going to a physician's office, maybe the best bet. Going to a Care Now center, maybe the best bet. Going to a standalone ER, maybe the best bet. Going into a hospital, maybe the best bet. You have to know which one to go. There's very little advice available for you. So if we go back to the players within the healthcare system again, and we say, where are you? Well, I want to be over here on the wellness side. I want to bring all my resources to bear and cause the healthcare system's resources to attempt to make me as well as can be, both at the beginning of life and at the end of life. And the other thing, I want to do it myself, and I want the healthcare professionals to do the same thing. Get me over here. Keep me out of the least healthy environments. Keep me out of the least healthy practices. Keep me out of the least environment where it creates dis-ease for me, and keep me as well and as at ease as I can be. And I as the patient will have a responsibility for that. So, by the way, in the end of life, this is something I saw. You have to make a decision of how your end of life will be handled. Not as flippantly as this guy says, as my name is Daniel Nathaniel Reed, I do not initial anything. So that's not exactly how this works. In your state, whichever your state is, and if you're watching this, this internet presentation, your state has rules for how to handle your end of life. It's your responsibility to know what that is. There are professionals within the system that will help you enable that. They will help you to put it into effect and make it legally binding. But you have to both know it, get it implemented, and advertise it. Now, I've hinted at a couple things here of your responsibilities. And I'll leave you with this. Your role within the continuum is to learn what it is that you know. Learn what it is that you don't know, and to fix the difference between those two. You have to figure out what you want to, how much of this system you want to control. You can see that the healthcare system, the healthcare systems continuum can hurt you. It can also help you. But you can help it to help you better if you understand the language. Get involved and stay involved. When you enter any sort of a healthcare continuum, healthcare facility, you are given some sort of a list of your rights and your responsibilities. It starts with when you go in your physician's office and they say, tell me a little about yourself. And you say, I'm just me. I'm 72-year-old, I have these characteristics, I worked in this environment, and that's it. But what I'm not telling you is I'm a healthcare professional, and you have to consider that any infection that I have may be a more serious infection because I play in the healthcare world. That's my responsibility to enable them to help me better. And I'll tell you, when I go to my practitioner and they say, and they start to talk to me as though I'm not a registered nurse, I say, do you know what's in my file? Have you looked at the history that you took when I first came here? Or are you just looking at today's illness? If you have no idea about me, how can you treat me? They have to know those things. So I encourage them to look at my file, which I gave them, which they demanded prior to them treating me. I lead the team that takes care of me, but I do it with their help. And whenever you have made a decision, whether it's a decision in the middle of your life or the decision at the end of your life, make those decisions known. Make them known in your chart, make them known with medical alert, make them known in advanced directives, make them known in the system which is used in your community. Make them known. You can't expect the healthcare continuum to know if you don't make your decision known. And then the last thing is, don't let other people give you disease or dis-ease. Don't let them give it to you. If they don't know cough etiquette, teach them cough etiquette. Or go somewhere else. And it doesn't matter if this is a family member or somebody sitting next to you on the airplane. Don't let them give you disease. Don't be in those toxic environments. Don't let them treat you wrong. Don't let them give you medicines at the wrong time. Don't let them not wash their hands when they come to you. Don't let them treat you and think they're treating someone else. This is some information on how to contact me, and it'll be on the website. But I'm available for any questions that you have. The thing that I want you to keep in mind is that you are responsible for your health. You have people to help you. You have a system out there that thinks that they're trying to help you. It doesn't always work out the way they want it to, and you can be a good agent of change for that. And thank you very much.
Thank you.